Have you ever felt like you're just drowning in health information? Scrolling through articles, maybe catching snippets here and there, and just wishing someone could, boil it all down for you, cut through the jargon, give you the really important stuff without completely overwhelming you?
Yeah, I get that. You want to be well informed, right? But time is so precious, and trying to cut through all that noise, it feels almost impossible sometimes.
Exactly.
Well, that's precisely why we're here. Welcome to the Deep Dive.
Today, our mission is really focused. We're exploring essential health concepts that honestly touch all of us: nutrition, elimination, inflammation, and infection.
And we're going to extract the most important nuggets of knowledge, maybe some surprising facts too, from, a whole wealth of information. The idea is to give you a real shortcut to being truly well-informed on these critical aspects of your health.
So what can you expect on this journey today? Well, we'll navigate through key body systems, we'll talk about some common conditions, and give you vital insights into what healthcare providers are really looking for, what they prioritize.
And we'll highlight those crucial warning signs you should absolutely never ignore. Plus, we'll dive into specific things to consider about medications you might encounter.
Right. And throughout all of this, patient safety is going to be front and center. This whole deep dive is really designed to arm you with practical knowledge, stuff you can immediately connect with your own health understanding, or even use in conversations with your own healthcare providers.
It really matters to you because, well, understanding these foundational elements empowers you. It helps you recognize important symptoms, engage more effectively, more confidently with your own healthcare team, and ultimately just feel more in control when navigating health information.
Yeah, it's not just theory, is it? It's about practical, actionable insights for your own well-being. So let's unpack this.
Let's do it.
Okay, let's start with the foundation, the real pillar of health. Nutrition. It's truly the bedrock, isn't it? What exactly do we mean when we talk about nutrition?
Well, at its core, nutrition is, it's the science of how your body takes in nutrients and then what those nutrients actually do for its functioning. It's absolutely essential for your ongoing health, your physical well-being.
Right.
Think about hunger, for instance, that bothersome feeling. It's actually a direct response to chemical mediators in your hypothalamus, sort of nudging you to eat and satisfy a really fundamental need.
So it's not just what we eat, but what our bodies are doing with it.
Okay. Speaking of what we eat, what are the key categories of nutrients? I always hear about macros and micros. It's the deal there.
Exactly. We generally break them down into a few main categories. First, you've got your macronutrients. These are the things your body needs in large amounts, primarily to supply energy. We're talking carbohydrates, proteins, and fats. They're the fuel, the building blocks.
Got it. Fuel and blocks.
Then you have the micronutrients, vitamins and minerals. Now, these are needed in smaller amounts, but they are just as vital. They're crucial for growth, maintenance, repair, often acting as catalysts for countless bodily processes. Smaller amounts, but still super important.
Totally. And of course, we absolutely cannot forget water. It's officially designated as an essential nutrient because it underpins virtually every single bodily function.
Water, right. Often overlooked, but so crucial. Are there, established guidelines we should be looking at for how to balance all these?
Oh, absolutely. The USDA publishes the dietary guidelines for Americans and also the MyPlate plan. These are pretty widely recognized frameworks for healthy eating, and they're designed specifically to help you integrate all these essential nutrient categories into a balanced diet.
Okay. And what's the role of, say, a healthcare professional, like a nurse, in all of this? Is it just about telling people what to eat?
Oh, far from it. Nurses play a really pivotal role, not just in educating patients about smart food choices and promoting overall health, but also in effectively managing illness and disease as it relates specifically to nutrition. It's actually a highly collaborative approach.
Collaborative, how so?
Well, they often work with a whole team. You might have dietitians for specialized meal plans, occupational and physical therapists who might help with mobility related to feeding, and of course, primary care providers. And this collaboration can even extend to very advanced interventions like enteral or parenteral nutrition tube feeding or IV nutrition, or even surgical considerations for severe nutritional issues.
Wow, okay. That's a great overview of the basics. Let's maybe move from general nutrition to a really common condition that impacts digestion. Gastroesophageal reflux disease, or GERD. We all hear about heartburn, but what exactly is GERD?
Right. GERD is a really common condition where you experience inflammation of the esophagus.
Yeah.
That tube connecting your mouth to your stomach. And that inflammation is due to the reflux or the backflow of stomach contents. So it's not just a little burn, it's actual irritation and inflammation happening in the esophagus lining.
Okay, so actual inflammation. What are the critical symptoms then that we should be assessing for if we suspect GERD? What are the main cues?
When a healthcare provider is assessing for GERD, they're looking for some key indicators. Things like the nature and frequency of the heartburn itself, how it relates to when you eat meals, your smoking habits, which are a huge risk factor.
Right, smoking.
Yeah. And any difficulty swallowing, which we call dysphagia, and also that uncomfortable sensation of fullness in the throat. These cues are really vital for pinpointing the severity and the impact of the GERD.
Okay, so once it's identified, what are the priority interventions? Are there practical steps we can take for relief and, importantly, for safety?
Yes, definitely. Diet management is, well, it's of overarching importance. And like you said earlier, it's not just about avoiding spicy food, but it's a comprehensive approach to reduce irritation overall.
Makes sense.
And here's a really vital safety point, something you can implement right away. Avoid eating or drinking anything within 2 hours of bedtime. This is a pretty strict rule, and the reason is when you lie down shortly after eating, gravity just doesn't help keep stomach contents down anymore.
Right, gravity's not on your side then.
Exactly. It increases the likelihood of reflux. Plus, your stomach is actively producing acid after a meal. So this timing piece is crucial for preventing that nighttime reflux and, the complications that can come with it.
So gravity is our friend, or can be. Does that apply to how you sleep too?
Absolutely. Another vital positional safety intervention is to elevate the head of your bed about 4 to 6 inches at night. This might seem like a small adjustment, maybe using blocks or a wedge, but it uses gravity to prevent stomach contents from flowing back into your esophagus while you sleep. It's a simple, but actually pretty powerful strategy for both comfort and reducing symptoms.
Simple but effective. What about medications?
Oh yeah, medication adherence is essential too. Taking prescribed medications consistently, exactly as directed by your provider, is key to manage symptoms and prevent those longer-term complications.
Speaking of complications, what are the long-term risks or potential issues with GERD if it's not managed well?
They can be quite serious, actually. Potential complications include esophagitis, which is severe inflammation, Barrett's esophagus, which is a precancerous change in the esophageal lining that needs careful, regular monitoring, respiratory complications that can arise from aspirating stomach acid into the lungs, and even dental problems because of the acid erosion on your teeth.
Wow.
And here's a really crucial medication consideration and a patient safety point. Long-term use of proton pump inhibitors, or PPIs, these are very common GERD medications. Well, their long-term use can increase your risk of osteoporosis. That's vital information to be aware of and definitely something to discuss with your healthcare provider if you're on them for a long time.
That's a really important safety point about PPIs. Good to know. Are there surgical options for GERD too?
Yes, there are. Nissen fundoplication surgery might be considered if symptoms just aren't responding well to the medications and lifestyle changes, or if there's an associated hiatal hernia. This procedure basically tightens the junction between the esophagus and stomach. It can be performed using minimally invasive laparoscopic techniques or sometimes traditional open surgery.
Okay. Moving on slightly, let's talk about peptic ulcer disease, or PUD. How does this compare to GERD, and what's the main cause?
Right, PUD. This involves ulcers, actual open sores, specifically in the lining of the stomach or the duodenum, which is the first part of your small intestine. And a very common cause, this is important to highlight, is infection with a bacteria called H. pylori.
So not just acid like in GERD, but often an actual infection causing the sore. How do these ulcers develop? Are they all the same?
Good question. Not always the same. Ulcers can be acute, meaning they're relatively short-lived and typically heal pretty quickly. Or they can be chronic, which involves a much longer duration and deeper erosion into the tissue. And yeah, H. pylori is frequently implicated in this ulceration. It damages that protective lining of the stomach or duodenum.
What increases someone's risk for getting PU?
There are various factors that contribute. Beyond that chronic H. pylori infection, certain dietary factors play a role. The use of NSAIDs like ibuprofen or naproxen and corticosteroids can significantly increase ulcer risk. That's a really key medication consideration to be mindful of.
Ah, those common pain relievers.
Exactly. Also, caffeine and alcohol consumption, smoking, certain underlying diseases, and even stress can all play a role in developing PU.
This is where it gets interesting for someone listening, I think. How do you know if it's a gastric ulcer, one in the stomach, versus a duodenal ulcer in the small intestine? Are there distinct pain patterns that can help tell them apart?
This is a crucial differentiation. And yes, the pain profiles are often quite distinct. It's really helpful for diagnosis. For gastric ulcers, the pain is typically located in the high epigastric region, sort of upper middle abdomen. It's often described as having a gnawing quality. Characteristically, this pain occurs 30 to 60 minutes after eating.
Okay, after eating.
Right. You might also experience nausea and vomiting. And uniquely, the pain, often burning or gnawing, is frequently worse at night and in the early morning. It might be relieved by food, but that's not always a consistent finding with gastric ulcers.
Okay, so gastric. Higher up, gnawing, worse at night or soon after eating. What about duodenal ulcers? How do they differ?
So for duodenal ulcers, the pain is distinctively in the epigastric area, but can also radiate to the back. Now, this pain characteristically occurs 2 to 3 hours after eating, so a bit later than gastric ulcers.
Later.
And here's the crucial differentiator, the really unique sign. Pain is often relieved by eating or by taking antacids. This is a significant clue. This type of pain also commonly awakens the patient during the night.
That difference in timing and relief with food is really helpful for understanding. How are these ulcers actually diagnosed then?
Diagnosis relies on a few key methods. Endoscopy is common. It allows the doctor to directly visualize the ulcers with a small camera. H. pylori tests, which can be breath tests, blood tests, or stool tests, are performed to confirm if that infection is present. A biopsy, a small tissue sample, might be taken during the endoscopy for closer examination. And a complete blood count, CBC, is often done to check for anemia, which could indicate bleeding from the ulcer.
Makes sense. Once diagnosed, what are the priority interventions? Is the approach different for an acute situation versus chronic management?
Yes, the approach definitely differs based on the situation. For acute care, maybe someone comes in with severe pain or bleeding, the focus is on immediate critical interventions to stabilize them and allow the ulcer to start healing. This typically includes maintaining MPO status, nothing by mouth, to rest the ulcer. Providing full IV fluids for hydration is crucial to combat dehydration. Administering medications specifically designed to heal the ulcerations. And if there's significant bleeding, blood transfusions are a vital patient safety measure.
Okay, that's the immediate crisis management. What about long-term chronic care?
For chronic care, the focus shifts to long-term management strategies. This includes really consistent medication adherence, sticking to a strict diet control plan, using stress reduction techniques, and absolutely stopping smoking.
And what about the specific medications for PUD, especially if that H. pylori infection is confirmed?
Right. Eradicating H. pylori is key if it's present, and it requires multi-drug regimens because the bacteria is quite resilient. We commonly see triple therapy, which combines clarithromycin, amoxicillin, and a proton pump inhibitor, PPI. Or there's quad therapy, which uses bismuth subsalicylate, tetracycline, metronidazole, and a PPI. These combinations are designed to effectively eliminate the infection.
So multiple drugs are needed.
Yes. And beyond those for H. pylori, other medications used include histamine receptor blockers, which also reduce acid production, antacids to neutralize stomach acid quickly, and mucosal protectors that essentially form a protective barrier over the ulcer to help it heal.
What are the most serious complications of PUD that people need to be aware of? These sound like things you don't want to mess around with.
Definitely not. Serious complications include hemorrhage, which is significant bleeding, gastric outlet obstruction, where the ulcer causes swelling or scarring that blocks food passage from the stomach, and perforation. That's a hole literally forming in the stomach or intestinal wall, and it's a life-threatening patient safety emergency requiring immediate surgery. There's also a long-term risk of developing gastric adenocarcinoma, a type of stomach cancer, though less common.
So when a patient is getting ready to go home after treatment, what's the priority education? What do they absolutely need to know for self-management? And crucially, when should they inform their healthcare provider about issues?
Empowering self-management is absolutely key for successful recovery and preventing recurrence. Patients need to understand the importance of taking their medication exactly as prescribed for the full duration. They need to avoid foods that personally irritate their ulcer. And here is a critical medication consideration and patient safety point. They must discontinue aspirin, ASA, or NSAIDs for about 4 to 6 weeks while the ulcer heals. This is extremely important to prevent further irritation and bleeding.
That NSAID point is huge.
It really is. Also, smoking and alcohol cessation are vital. They need to understand the importance of managing stress, and they must be aware of specific signs and symptoms to report promptly to their healthcare provider. Things like persistent severe pain, vomiting blood, or passing black Tory stools which indicate bleeding.
Okay, let's shift gears now to a pediatric concern, pyloric stenosis. What is this condition, and why is it primarily an issue for infants?
Right, pyloric stenosis. This is a narrowing of the pyloric canal, which is basically the opening between the stomach and the duodenum, the first part of the small intestine. This narrowing physically prevents food, like milk or formula, from easily passing out of the stomach. It's a condition that often develops after birth, typically in the first few weeks or months of life. It's not usually something a baby is born with at that exact moment.
So what's the core problem physiologically? What's causing the blockage?
Well, the definitive cause isn't fully known, but what happens is the muscle surrounding the pylorus, that exit valve of the stomach, thickens and hypertrophies. It gets bigger. This thickening creates a physical obstruction, blocking or severely restricting the flow of food entering the small intestines.
How would a parent or a healthcare provider identify this in an infant? Are there really unique signs we should be looking for? These seem pretty specific.
Absolutely, and these unique signs are crucial diagnostic cues for infants. The most distinctive, the hallmark sign, is projectile vomiting. This isn't just spitting up. The baby forcibly vomits stomach contents, sometimes over a considerable distance, and it typically gets worse as the stenosis progresses.
Wow, projectile.
Yeah. Despite this significant vomiting, the baby often exhibits persistent hunger, seeming ravenous and wanting to feed again almost immediately after vomiting. On physical examination, a unique sign is sometimes palpable. An olive-shaped lump can be felt in the umbilical region, the upper abdomen. You might also observe visible wave-like contractions moving across the baby's abdomen as the stomach muscles are trying desperately to force food through that narrowed opening.
That sounds distressing to see.
It can be. And critically, these babies often fail to gain weight, or they might even start losing weight, which is a key indicator of malnourishment. And for healthcare providers, monitoring the number of wet diapers is a priority nursing assessment to gauge the baby's hydration status. Dehydration is a significant and dangerous risk with all that vomiting.
So if these signs are present, what are the priority interventions, especially considering surgery is often the fix?
Right. Surgery is the definitive treatment. Before surgery, priority interventions include monitoring the baby's weight daily and meticulously tracking intake and output. I know, how much they drink versus how much they urinate or vomit to assess their fluid balance. An NG tube, or a nasogastric tube, is usually inserted preoperatively. This helps to decompress the stomach, preventing further vomiting and preparing the stomach for the upcoming surgery. It's also vital to prepare both the baby and the parents emotionally, offering clear explanations and support during a stressful time.
And what about after the surgery?
Post-surgery, a critical patient safety measure is maintaining strict NPO status, nothing by mouth, until feedings are specifically ordered by the healthcare team. We monitor carefully for any signs of abdominal distension, and then we initiate small, gradual feedings as tolerated, increasing the amount very slowly based on the baby's response.
What are the potential complications if this condition isn't caught or treated promptly?
If it's missed or treatment is delayed, significant complications can arise. These include failure to thrive, which is severe malnutrition, jaundice, severe dehydration, electrolyte imbalances due to the persistent vomiting, and even erosion and bleeding of the stomach lining itself.
So when a child is discharged after the corrective surgery, what critical instructions do parents need? What specific signs should make them call their healthcare provider right away?
Discharge teaching is absolutely paramount for patient safety. Parents must understand the importance of attending all follow-up appointments to monitor their child's recovery and growth. And crucially, they need a very clear, specific list of signs that require immediate notification of their healthcare provider, HCP. These include if the prescribed analgesics are not controlling the baby's pain, if there's no bowel movement for a concerning period, any new abdominal distension, a fever greater than 101.3 degrees Aphanar. That specific temperature threshold is important. Any vomiting after the baby starts taking clear liquids, or any signs of infection at the surgical site like redness, bleeding, or pus. All of these are vital patient safety concerns needing prompt medical attention.
Okay, let's move on to another major metabolic disorder that affects millions, diabetes. Can you give us the fundamental overview?
Sure. Diabetes isn't just one single condition. It's actually a group of complex disorders that affect your metabolism and can impact multiple organ systems throughout the body. And this is really key. Nurses play such a critical role in educating patients on effective self-management strategies. The goal is to help them achieve optimal health and prevent the many potential complications of diabetes. Empowerment through education is truly central to living well with this condition.
What are the general clinical manifestations we might see, and how is diabetes typically diagnosed?
Well, symptoms can vary quite widely depending on the type of diabetes and the patient's age, but some common general signs include what are sometimes called the polys, polyuria, which is frequent urination, polydipsia, or increased thirst, and polyphagia, which is increased hunger. You might also see just general increased thirst, nausea, vomiting, and sometimes abdominal pain.
And for diagnosis?
For diagnosis, key tests include a fasting plasma glucose, FPG, which is often an initial screening test. Random glucose tests and 2-hour post-load glucose tests, glucose tolerance tests, are also used. But crucially, hemoglobin A1C, HbA1c, greater than 6.5% is considered a definitive diagnostic marker for diabetes. The A1C test reflects your average blood sugar levels over the past 2 to 3 months, giving a longer-term picture.
What about older adults? Does diabetes present differently?
That's a great point. Diabetes is highly prevalent in older adults, but early detection can sometimes be challenging in this population. Symptoms may be absent, or they might be atypical compared to younger adults, making regular screening extremely important for older individuals.
So for nursing management, it really sounds like patient education and promoting self-care are paramount, right?
Exactly. Patient and family education is absolutely fundamental for effective self-care in diabetes. Nurses help patients adhere to their prescribed care plans, discuss appropriate food choices tailored to their needs, and help them manage illness effectively, as illness can significantly impact blood sugar levels. A priority nursing intervention is frequent monitoring of blood glucose levels, which is a critical patient safety measure to guide treatment adjustments. Beyond just blood sugar, promoting good hygiene is crucial, especially in meticulous foot care to prevent infections and ulcers, and managing periodontal disease, gum disease, as both are common and serious complications associated with diabetes.
Okay, so we've covered how the body gets its fuel. Now let's explore how it gets rid of waste. Elimination. This is definitely an indirect gauge of our overall health, isn't it?
It absolutely is. Elimination, simply put, is the secretion and excretion of physiological waste products by your kidneys and intestines. And you're completely right. The processes of elimination, both urinary and bowel, serve as an indirect yet vital gauge of your overall general health. Changes here can signal issues elsewhere.
And what kind of things can cause changes or alterations in elimination patterns?
Alterations in elimination can be quite telling, as you said. They might reflect impaired function of other body systems, think neurological issues impacting bladder control, or cardiovascular problems affecting kidney function. They can be side effects from medications, which is a specific medication consideration we always need to think about. Imbalances in hydration or nutrition levels definitely play a role. Changes in neurological function impacting nerve signals to the bladder or bowel, or even just significant increases or decreases in food and fluid intake.
What influences urinary elimination specifically? Seems like a lot can affect it.
Oh, many factors. Your fluid and food intake, what and how much you drink and eat, obviously plays a huge role. Your muscle tone, particularly your pelvic floor muscles, is key for bladder control. Psychosocial factors, like needing privacy or feeling stressed, can influence your ability to void. Underlying pathological conditions like kidney disease or bladder infections have a direct impact. Surgical and diagnostic procedures, especially those involving the urinary tract or anesthesia, can affect function. And medications, whether they act as diuretics increasing urine output or antispasmodics affecting bladder muscle, all have an effect.
Do genetics or age play a role?
Yes. Genetic predispositions and lifespan considerations also influence urinary elimination patterns across different age groups. Infants, preschoolers, school-age children, pregnant women, and older adults all have distinct patterns and potential challenges related to urinary elimination at different life stages.
Are there modifiable risk factors for urinary issues? Things we can actually change?
Yes, there are definitely factors you can influence. For instance, chronic bowel problems like constipation can put physical pressure on the bladder, affecting its function. Certain medical conditions, such as diabetes, can impact bladder nerves and function over time. Medical procedures requiring anesthesia can temporarily affect bladder control. And pharmacologic treatment for other conditions can sometimes have urinary side effects.
Is there a standard screening for urinary problems, and what's a critical safety takeaway here?
Currently, no single standard screening procedure exists for general urinary elimination issues like we have for, say, colon cancer. However, questions about elimination patterns should be part of regular health checkups, especially for older adults where issues might be dismissed as normal aging. And here's a vital patient safety point. Urinary incontinence, that involuntary leakage of urine and urinary retention, the inability to fully empty the bladder, are never considered normal. They very often indicate another underlying medical problem that requires investigation by a healthcare provider. It's not just a nuisance symptom. It's a sign something else might be going on.
That's really important, never normal. What's involved in assessing urinary elimination, and are there cultural considerations to keep in mind?
Assessment typically involves a physical examination, a thorough health history interview focusing on symptoms and patterns, and various diagnostic tests like urinalysis, urine cultures, or imaging studies like ultrasound. Cultural considerations are important here too. We need to respect patient privacy and modesty, be sensitive to a client's potential preference for a clinician of the same gender, address any anxiety or embarrassment they might feel discussing these topics, and use clear, easily understood terminology to ensure comfort and cooperation.
What kind of interventions or therapies are available? Both things people can do themselves and things involving healthcare providers.
Right, we look at both. Independent interventions, things individuals can do themselves, include promoting healthy lifestyle habits, maintaining a healthy weight, getting regular exercise, and establishing good toileting habits. Avoiding delayed voiding and defecation is important. Also, avoiding straining the pelvic floor muscles to urinate, preventing constipation through a high-fiber diet, not smoking, which can irritate the bladder, ensuring adequate fluid intake, and avoiding known bladder and bowel irritants like caffeine or artificial sweeteners.
Okay, so lifestyle changes. What about collaborative interventions?
Collaborative interventions involve healthcare professionals. This includes pharmacologic therapies. For example, diuretics like loop, thiazide, or potassium-sparing types increase urine output. Anticholinergic medications can help reduce urinary frequency and treat certain types of incontinence. On the flip side, cholinergic medications can help promote urination for individuals experiencing retention. For cases of severe kidney failure, dialysis options include hemodialysis, where blood is filtered through an external machine, and peritoneal dialysis, where a solution is used within the abdominal cavity.
Let's talk briefly about a specific elimination issue in children. Enuresis or bedwetting. How is this defined?
Enuresis refers to involuntary urination that happens during sleep, or bedwetting. It's actually quite common among children and tends to be more prevalent in boys than girls. Typically, an older child, say age 7 or older, is considered to have enuresis, recognizing that the age at which a child achieves nighttime urinary continence can vary quite significantly.
What are the common causes for nighttime bedwetting, and what about daytime wetting issues?
Good question. For nocturnal enuresis, or nighttime bedwetting, the causes can be varied. It might be a simple maturational delay in bladder control development. Sometimes it's related to uncompleted toilet training. It could be an overproduction of urine specifically at night, or difficulties in arousal from sleep. The child just doesn't wake up when their bladder is full. Underlying medical conditions that increase urine volume, like undiagnosed diabetes, can play a role. Constipation is another factor, as is, less commonly, structural abnormalities of the urinary tract. For diurnal enuresis, or daytime wetting, bladder irritability and constipation are often the common culprits.
What are the typical treatments for enuresis?
Treatment approaches often start with conservative measures. Bladder training, which involves exercises and schedules to increase bladder capacity and awareness, is one approach. Moisture alarms, which are devices that sound an alarm at the first sign of wetness to help condition the child to wake up, can be effective. And in some cases, specific medications might be prescribed, usually for short-term use, or if other methods fail.
Okay. Now, let's shift to a very painful elimination issue. Urinary calculi, more commonly known as kidney stones. What are they and just how painful can they be?
Kidney stones, or urinary calculi, are essentially hard mineral deposits that form inside your kidneys. They can vary dramatically in size, from tiny like a grain of sand to quite large, and they can lodge anywhere in the urinary tract, the kidneys, the ureters, the bladder. They are characteristically known for causing very severe pain. The terms lithiasis, nephrolithiasis, and urolithiasis all basically refer to stone formation, whether it's in the kidney itself or elsewhere along the urinary pathway.
What causes them to form physiologically?
Several factors can contribute to their formation. Underlying infection in the urinary tract can be a factor. Urinary stasis, where urine isn't flowing freely and pools in the urinary tract, creates an environment where minerals can precipitate out. Immobility can also contribute to stasis. The stones themselves are typically composed of various substances, most commonly calcium oxalate or calcium phosphate. Uric acid stones and struvite stones, often related to infection, are other types.
So the pain is severe. Are there unique signs and symptoms depending on exactly where the stone is located in the urinary tract?
Yes, the symptoms, especially the pain characteristics, can vary significantly depending on the stone's size and precise location. Stones that are still up in the kidney calyces or pelvis might actually present with few symptoms, or maybe just a dull, aching flank pain, especially if the urinary flow is only gradually or partially obstructed.
Okay, so maybe not dramatic initially if it's in the kidney?
Right. Stones down in the bladder can cause a dull suprapubic pain low in the abdomen, often noticeable with exercise or during voiding. Gross hematuria, or visible blood in the urine, is also common with bladder stones. But a stone that moves into and obstructs the ureter, that narrow tube connecting the kidney to the bladder, that causes the most distinctive and severe symptom, renal colic.
Renal colic, that sounds bad.
It is. It's typically described as excruciating, severe, sharp, wave-like pain, often starting in the flank and radiating down towards the groin. It's associated with the ureter spasming as it tries to push the stone along. This intense pain often triggers a sympathetic nervous system response. The person might become pale, feel cool and clammy, experience nausea, and vomit. This specific presentation of intense colicky pain is a critical and unique sign of a ureteral stone. And sometimes a urinary tract infection, UTI, can occur alongside the stone.
What are the potential complications of kidney stones besides the pain?
Complications primarily revolve around obstruction. This can be gradual or acute. Prolonged obstruction can lead to hydronephrosis, where urine backs up behind the stone, causing pressure buildup in the kidney, potentially leading to kidney damage. You also see the severe colicky pain, hematuria, UTIs, damage to the kidney tissue, parenchyma, and those associated GI symptoms like nausea and vomiting.
What's the pharmacologic approach for managing an acute kidney stone episode, and then what about preventing future stones?
For an acute episode, the absolute focus is on immediate relief. Analgesia for the severe pain is a top priority nursing intervention, often requiring strong pain medications. Hydration, either encouraging significant oral fluid intake or providing IV fluids, is crucial to help flush the stone through the urinary tract. And antiemetics are given to manage the nausea and vomiting, often associated with the intense pain.
So pain relief and fluids. What about prevention?
To inhibit or prevent further stone formation, especially if the stone composition is known, specific medications might be prescribed long-term. For example, thiazide diuretics can help reduce calcium excretion in the urine for those prone to calcium stones. Potassium citrate can help make the urine less acidic and inhibit certain types of stone formation. These are specific medication considerations based on the type of stone.
Are there surgical options if the stone doesn't pass on its own?
Yes. Surgical intervention depends on several factors. The stone's location and size, whether it's causing complete obstruction, the impact on renal function, the presence of infection, and the patient's overall health. Options include lithotripsy, most commonly extracorporeal shock waves lithotripsy, ESWL, which uses focused shock waves from outside the body to break the stone into smaller fragments that can be passed. Other options involve procedures to directly access and remove the stone, like placing a ureteral stent to bypass obstruction, ureteroscopy, inserting a scope through the urethra and bladder into the ureter, or actual surgical removal procedures like ureterolithotomy, pyelolithotomy, or nephrolithotomy.
What about nursing care for kidney stones? Are there any particularly unique or critical interventions?
As mentioned, pain management is absolutely a critical priority nursing intervention. Beyond that, a very unique and vital nursing intervention is to strain all urine that the patient passes. We use a special filter or gauze to catch any stones or fragments that are passed. Collecting these stones is crucial because analyzing their composition helps the healthcare provider determine the cause and guide future prevention strategies. Nurses also encourage a high fluid intake, typically aiming for 2-3 liters of non-sugar sweetened beverages per day, to promote stone passage and prevent dehydration and future stone formation. Education on prevention strategies, often dietary changes based on stone type, is crucial. And we strongly emphasize the importance of adherence to follow-up appointments with the healthcare provider for ongoing monitoring and management. Okay, we've talked quite a bit about urinary elimination. Let's move now to the other major elimination pathway, bowel elimination. This is another critical rhythm of the body, right? What influences this process? Absolutely. Bowel elimination is just as vital. Many factors influence it, similar in some ways to urinary elimination, but with distinct aspects. Your diet and fluid intake are huge, particularly fiber content. Your activity levels play a big role. Regular exercise helps stimulate bowel motility. Established defecation habits responding to the urge versus ignoring it matter. Diagnostic procedures, especially those involving the bowel like colonoscopies and various medications, can significantly affect bowel function. This is a common specific medication consideration. Anesthesia and surgical procedures often slow down the bowels temporarily. Underlying pathological conditions, pain, which can lead to avoidance of defecation, and psychological factors like stress or anxiety all impact bowel elimination.
Do genetic and lifespan considerations play a role here too? What's unique for different age groups, say newborns versus older adults or pregnant women?
They definitely do. Patterns change significantly across the lifespan. For newborns and infants, the very first stool is called meconium. It's thick, sticky, and blackish green. This transitions over a few days to entirely fecal stool. Stool frequency in infants varies incredibly widely, from multiple times a day to once every few days, especially in breastfed babies. Consistency starts soft and liquid, becoming firmer when solid foods are introduced. The color typically ranges from tan to yellow to green, and the odor is usually faint until solid foods are started.
And what about older adults? I often hear that constipation is a common issue for them.
Yes, in older adults, constipation is a very common concern. This is often due to a combination of factors like reduced activity levels, potentially inadequate fluid and fiber intake, weakening of abdominal and pelvic muscles, and medication side effects. Many common medications for older adults can cause constipation, another specific medication consideration. And here's a crucial patient safety point we need to emphasize. Laxative overuse can actually inhibit the natural bowel reflexes and may paradoxically worsen or cause constipation rather than curing it. Dependency can develop.
That's counterintuitive, but important.
It is. It's also important for older adults to try and respond to the gastrocolic reflex, that natural urge to defecate, often felt after eating. And this is a critical point for HCP communication. Any significant change in bowel habits that persists for several weeks should always be referred to a primary care provider for evaluation. It shouldn't just be dismissed as getting older.
Good advice. What about pregnant women? They often experience changes too, right?
Oh, definitely. Pregnant women frequently experience delayed gastric emptying and decreased peristalsis, the muscular contractions that move food through the gut, often due to hormonal changes. This can lead to bloating and constipation. The enlarging uterus also physically presses on the intestines, aggravating these symptoms. Hemorrhoids are common due to increased pressure in the pelvic region. After giving birth, bowels can be sluggish for a bit, and pain from the delivery itself or from perineal repairs like episiotomies might lead women to delay elimination, which can worsen constipation. Flatulence can also be a common, though temporary, issue after a cesarean birth.
What are some of the more serious alterations in bowel elimination and their typical signs?
We see things like impaction, which is a severe form of constipation where a hardened stool gets stuck in the rectum or colon. It can be caused by underlying issues like bowel cancer, an obstruction, or just severely hardened feces. Symptoms include persistent constipation, sometimes paradoxical incontinence, where liquid stool leaks around the impacted mass, cramping and straining during attempted defecation. Bowel cancer is another serious alteration. It might initially be asymptomatic, which is why screening is so important. When symptoms do arise, they can include blood in the stool, either visible or hidden alcohol, a noticeable change in bowel habits, like new onset constipation or diarrhea, abdominal pain, unexplained weight loss, anemia due to chronic blood loss, bowel obstruction, and vomiting. And then there's obstruction itself, a blockage somewhere in the bowel. Symptoms typically include abdominal distension, cramping pain, constipation, sometimes diarrhea, especially if the obstruction is partial, and vomiting, often of fecal-like material if the obstruction is lower down.
How can we work towards preventing some of these bowel issues?
Prevention involves addressing those modifiable risk factors we talked about, improving diet by increasing fiber and fluids, managing long-term medication used carefully with a provider, practicing good hygiene, especially related to food preparation and hand washing. And critically, screening for colon cancer, according to recommended guidelines, is an incredibly important patient safety and preventive measure. Early detection makes a huge difference.
How are these various bowel conditions typically assessed and diagnosed?
Assessment starts with a thorough nursing assessment, including obtaining a detailed nursing history about bowel habits, diet, medications, and symptoms, followed by a physical examination, including listening to bowel sounds and palpating the abdomen. Cultural considerations like respecting privacy and modesty during exams and ensuring procedures are explained clearly are important. Diagnostic tests can range from blood tests and fecal tests, like the fecal occult blood test or tests for specific pathogens, to a digital rectal exam, colonoscopy, which allows direct visualization of the colon, X-ray imaging, and sometimes more specialized tests like anorectal manometry to assess sphincter function, or a colorectal transit study to measure how quickly material moves through the colon.
And what are the typical interventions and therapies used?
Interventions can be categorized. Independent interventions are actions individuals can take themselves, often guided by healthcare advice. increasing intake of fluid and fiber, receiving education about the impact of dietary choices, practicing bowel training, establishing a regular time for defecation, performing Kegel exercises to strengthen pelvic floor muscles, which can help with fecal incontinence, and sometimes using biofeedback techniques. Collaborative interventions involve healthcare professionals and may include prescribing laxatives, antidiarrheal agents, or stool softeners. In more serious cases, surgery might be necessary, along with specific treatments for complications like obstruction, ulceration, or perforation.
Let's get a bit more specific about bowel obstruction. What's the medical and surgical management approach?
Okay. For a small bowel obstruction, the initial medical management often includes placing an NG tube, nasogastric tube, to decompress the bowel, essentially sucking out accumulated fluid and gas to relieve pressure above the blockage. 4 fluids are crucial for hydration. Surgery might become necessary if there are signs of bowel strangulation or necrosis, tissue death, or to address the underlying cause, such as repairing a hernia, dividing adhesions, bands of scar tissue that can kink the bowel, or performing a partial colectomy, removing a section of the colon.
And for a large bowel obstruction?
For a large bowel obstruction, management might involve aggressive fluid replacement to correct dehydration and electrolyte imbalances. Sometimes a colonoscopy can be used therapeutically, for instance, to remove an obstructing polyp or decompress the colon. A cecostomy, which is a surgical opening into the cecum, the beginning of the large intestine, might be created for drainage. More definitive treatment often involves surgical resection of the obstructed segment, potentially requiring a temporary or permanent colostomy, creating a stoma, and opening on the abdomen for waste elimination.
What's the most critical priority education for patients being discharged after treatment for a bowel obstruction? What do they absolutely need to report to their healthcare provider, and what precautions should they take?
Discharge education is vital for preventing recurrence or complications. Patients should be encouraged to sit down and try to have a bowel movement when they feel the urge, rather than delaying. Trying to establish a consistent bowel movement schedule can also be helpful. And critically, they must understand the specific symptoms of a recurrent bowel obstruction and report these to their healthcare provider, HCP, immediately. This is a direct HCP communication and crucial patient safety instruction. These symptoms would include things like severe abdominal pain, persistent vomiting, inability to pass gas or stool, or increasing abdominal distension.
Okay, immediate reporting is key.
Absolutely. If surgery resulted in an ostomy, extensive education on proper ostomy care is absolutely vital for patient safety and effective self-management. Patients need to understand the importance of attending follow-up appointments for monitoring their recovery. And a practical patient safety point: they should typically be advised to avoid heavy lifting for a period after surgery to prevent strain on surgical sites or the potential recurrence of hernias.
Let's dive into a really complex area now. Inflammatory bowel disease, or IBD. This is often confused with IBS, irritable bowel syndrome, but they're fundamentally different, correct?
Yes, profoundly different, and making that distinction is crucial right up front. IBD is a group of disorders characterized by chronic inflammation and ulceration of the bowel. It's marked by periods of exacerbation, or flare-ups, and periods of remission. IBD primarily encompasses 2 conditions: Crohn's disease and ulcerative colitis. Irritable bowel syndrome, IBS on the other hand, is considered a functional bowel disorder. It involves changes in bowel motility and sensation, likely due to neuromuscular control abnormalities, but it doesn't cause the chronic destructive inflammation and ulceration seen in IBD. That's the critical distinction. IBD involves actual inflammation and potential damage to the bowel wall, while IBS does not.
Okay, inflammation is the key difference. Let's break down Crohn's disease first. What's unique about its pathophysiology? Where does it affect the GI tract, and how deep does it go?
Crohn's disease is a chronic inflammatory bowel disease that has some very unique characteristics. First, it can affect any part of the GI tract, literally anywhere from the mouth all the way down to the perianal area. However, distinctively, the rectum is seldom involved, which is different from its counterpart, ulcerative colitis.
Any part, but usually spares the rectum.
Yeah,
got it.
Right. Another key feature is that the inflammation in Crohn's extends through all layers of the intestinal wall. We call this transmural inflammation. This leads to deeper damage compared to UC. The disease involves unpredictable periods of remission and relapse, often leading to fibrosis, scarring, and symptoms of blockage or narrowing stenosis.
And what does the inflammation look like?
The inflammation often starts focally, then progresses to ulceration. These ulcers can become deep, leading to fissures and abscesses. Over time, this deep inflammation and subsequent healing attempts can lead to a characteristic cobblestone appearance of the bowel lining on endoscopic view. And a real hallmark of Crohn's is that the inflammation occurs in a skip pattern, meaning you'll find segments of normal, healthy-looking bowel interspersed between diseased portions. It's not continuous inflammation.
Okay, skip pattern, transmural, cobblestone, any part but rectum. What are the typical clinical manifestations of Crohn's?
Common symptoms include persistent diarrhea, abdominal cramping, and tenderness, often felt in the lower right abdomen. Weight loss is also very frequent due to malabsorption and decreased intake. And here's a unique sign often associated with Crohn's: RLQ, right lower quadrant pain, that is specifically not relieved by defecation. Having a bowel movement doesn't make that particular pain better.
What are the potential complications associated with Crohn's disease?
Because the inflammation goes to the full thickness of the bowel wall, complications can be significant. These include abscesses, collections of pus, peritonitis if the bowel perforates, a severe patient safety emergency, fistulas, abnormal tunnel-like connections between different loops of bowel or between bowel and other organs like the bladder or skin, vitamin deficiencies due to malabsorption in the affected small bowel segments, and an increased long-term risk of developing colon cancer, although the risk is generally considered higher in ulcerative colitis.
Now, let's contrast that with ulcerative colitis, UC. What's its unique pathophysiology? Where and how deep is the inflammation, typically?
Ulcerative colitis has a very different pattern. It primarily involves the mucosa and submucosa, essentially the inner layers of the large bowel, the colon. Unlike Crohn's, the rectum is almost always involved in UC, and the inflammation typically starts in the rectum and extends upwards in a continuous fashion. There are no skip lesions. The inflammation is contiguous.
So, continuous, superficial layers, large bowel only, and starts in the rectum.
Exactly. This continuous inflammation leads to changes in the colon over time, often causing it to become rigid and shortened. On visual inspection during colonoscopy, the mucosa looks red, granular, and bleeds easily. You might see tiny bleeding spots called petechial hemorrhages.
What are the hallmark clinical manifestations for UC? What's distinctive about its symptoms, especially the stool?
Diarrhea is very prominent in UC, as it is in Crohn's. However, a defining characteristic and unique symptom of UC is that the stool consistently contains blood, mucus, and pus. This is a key differentiator. In severe cases, patients might experience 6, 10, or even more bloody stools per day. Other common symptoms include cramping, typically in the LLQ, left lower quadrant, fatigue, anorexia, loss of appetite, and generalized weakness. Systemic manifestations like arthritis and eye inflammation, uveitis, can also occur, similar to Crohn's.
What are the major complications specific to ulcerative colitis?
The most feared acute complication of severe UC is toxic megacolon. This is a life-threatening condition where the colon rapidly dilates and becomes paralyzed, increasing the risk of perforation. The critical patient safety emergency. Hemorrhage, severe bleeding, and perforation, a hole in the colon wall, are other severe potential complications, also patient safety emergencies. And as mentioned, there's a significant long-term risk of developing colon cancer, particularly if the disease affects a large portion of the colon and has been present for many years.
Do Crohn's and UC share any common risk factors?
Yes. While they are distinct diseases, they do share some overlapping risk factors. These include a history of allergies or other immune disorders, a genetic predisposition, about 10–20% of patients have a first-degree relative with IBD, possibly high protein levels of tumor necrosis factors, TNF, smoking. Interestingly, smoking seems to worsen Crohn's, but may be somewhat protective against UC, though quitting is always recommended for overall health. Use of oral contraceptives or heavy NSA use. Certain gene mutations, like within the NOD2 gene, are more strongly associated with Crohn's. The typical age of onset for both conditions is between 15 and 35 years old.
How are these IBD conditions diagnosed definitively? What are the key tests?
Diagnosis involves piecing together information from various tests. Key lab tests often show elevated erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP, especially during a severe flare-up, indicating systemic inflammation. Imaging studies are important. A plain abdominal X-ray might be done initially, especially if toxic megacolon or perforation is suspected, patient safety. A CT scan can show the extent of bowel wall inflammation. An upper GI series with small bowel follow-through might help differentiate Crohn's, which can affect the small bowel, from UC, which typically doesn't. What about endoscopy? Colonoscopy is absolutely crucial. It allows the physician to directly visualize the extent of the disease throughout the colon, evaluate for complications like strictures, narrowing, or pseudopolyps, inflammatory bumps, and most importantly, take biopsies, tissue samples. The biopsy results are vital to confirm the diagnosis of IBD and, critically, to help distinguish ulcerative colitis from Crohn's disease based on microscopic features. Sigmoidoscopy, a shorter scope exam, can confirm rectal involvement, common in UC. Liver function tests might also be checked.
Is a barium enema still used?
It's important to note that barium enema, an older imaging technique, is rarely used nowadays in the context of active IBD, particularly UC, due to the risk of potentially inducing or worsening toxic megacolon. That's a critical patient safety concern.
Okay, so colonoscopy with biopsy is key. Let's talk about the pharmacologic therapy for IBD. It sounds like it can be quite complex with different classes of drugs.
It definitely can be complex, often requiring a step-up or sometimes a top-down approach depending on severity. A common class used, especially for mild to moderate UC and sometimes Crohn's, is aminosalicylates. These include drugs like sulfasalazine, ulsalazine, and mesalamine. They're used to treat exacerbations for chronic maintenance therapy to keep the disease in remission and to prevent flare-ups. A specific medication consideration you should mention to patients on sulfasalazine is that it may cause a harmless but potentially alarming yellow-orange discoloration of the skin and urine.
Good to know about the color change. What else?
For more moderate to severe disease, or if aminosalicylates aren't enough, immunosuppressants like azathioprine or 6-mercaptopurine, 6-MP, are used to reduce the underlying inflammation. However, here's a crucial medication consideration and patient safety point regarding 6-MP. It works slowly and should generally not be started or given when the disease is acutely active and a faster response is needed. Corticosteroids are often used short-term for acute flares to quickly reduce inflammation.
Are there stronger medications?
Yes. For moderate to severe disease that doesn't respond well, we have immune response modifiers, often called biologics. These target specific proteins involved in the inflammatory process, like tumor necrosis factor, TNF inhibitors, e.g. infliximab, adalimumab. Antibiotics might be used, particularly for complications like abscesses or fistulas in Crohn's. And what about antidiarrheal agents like loperamide, Imodium? A specific medication consideration here is that while they can help with symptoms sometimes, they may not be effective and could even be harmful during acute exacerbations, especially in severe UC, due to the risk of slowing bowel motility too much and contributing to toxic megacolon.
So be cautious with antidiarrheals during flares. What about non-pharmacologic therapy, especially dietary and lifestyle adjustments? Are there crucial differences here between Crohn's and UC?
Dietary management is highly individualized in IBD, as specific food triggers can vary greatly. While it's thought that antigens in the diet might stimulate exacerbations, identifying specific culprits can be tricky. Now, regarding fiber, increased dietary fiber might help reduce diarrhea for some people with IBD, particularly mild UC. However, here's a critical contrasting dietary recommendation. Crohn's disease patients, especially those with strictures or during active flares, should often avoid high fiber intake, as it can worsen symptoms like pain, bloating, and obstruction.
So fiber might help some UC, but avoid it in Crohn's flares. Interesting contrast.
Exactly. During an acute exacerbation of Crohn's disease, management might involve withholding food entirely, bowel rest, providing total parenteral nutrition, TPN, intravenously for nutrition, or using an elemental diet. An elemental diet is a special liquid meal replacement where nutrients are already broken down into their simplest forms, requiring minimal digestion and helping the bowel recover.
What are the general recommendations?
Generally, maintaining a well-balanced diet with adequate fluid intake is crucial, especially during severe disease, to prevent malnutrition and dehydration. Ensuring high protein, sufficient vitamins, and adequate calories is important for healing and energy. Patients are often advised to avoid cold foods, like ice cream or very cold drinks, and smoking, as both can increase intestinal motility and worsen symptoms. Planning for rest periods is important, especially during exacerbations, to promote healing. Identifying and avoiding personal triggers is key. In cases of severe anemia, hemorrhage, or perforation, blood transfusions may be necessary, a critical patient safety measure. And incorporating relaxation and stress management techniques can be beneficial for overall well-being, as stress can sometimes trigger flares.
When does surgery become necessary for IBD? And is it curative? This seems like a major point of difference.
Surgery is generally reserved for situations where medical management fails or when complications arise. These complications necessitate intervention for patient safety and include things like bowel obstruction that doesn't resolve, perforation, uncontrollable bleeding, internal or external fistulas that aren't healing, abscesses, or severe perianal disease, particularly in Crohn's.
And the curability aspect.
Here is the defining and crucial difference, a critical point for patient prognosis and education. For ulcerative colitis, surgery can be curative. A total proctocolectomy, which removes the entire colon and rectum with the creation of an internal pouch, like an oleoanal pouch or J pouch, to allow for relatively normal defecation, essentially eliminates the disease because UC only affects the colon and rectum.
So surgery can cure UC. What about Crohn's?
This is the crucial patient prognosis distinction. Surgery does not cure Crohn's disease. While surgery might be needed to remove severely diseased segments of bowel or treat complications, Crohn's has a high tendency to recur, often appearing in previously unaffected areas of the GI tract, sometimes near the site of the previous surgery. So, while surgery is sometimes necessary in Crohn's, it's generally approached more conservatively due to the likelihood of recurrence. That's a key contrasting fact for patient education. Various ostomy procedures, ileostomy, loop ileostomy, continent ileostomy, might also be performed depending on the extent and location of disease requiring removal. Interestingly, surgical removal of up to 80% of the small bowel can be tolerated in most adults, though it can lead to short bowel syndrome.
That difference in surgical outcome is massive. What's the nursing care focus for patients managing IBD? What are the priorities?
Nursing care involves a holistic approach, addressing the physical and psychosocial aspects of these chronic conditions. A priority nursing intervention is to schedule patient care to allow for uninterrupted rest periods throughout the day, especially during flares, to promote healing and conserve energy. We assist with dietary modifications and supplemental feedings if needed, reinforcing advice to avoid known irritants and sometimes dairy, depending on individual tolerance, providing comfort measures such as warm sitz baths for perianal discomfort common in Crohn's is important.
What are the priority assessments?
Priority nursing assessments include obtaining and monitoring daily weights to track nutritional status, checking stools carefully for frequency, characteristics like blood, mucus, pus, and performing tests for occult bleeding, hidden blood. We evaluate the overall pattern and frequency of stool passage.
And patient safety and adherence.
Ensuring adherence to the often complex medicine regimen and follow-up appointments is crucial for patient safety and long-term management. And given the increased long-term risk of colon cancer in IBD, particularly in long-standing extensive UC, a key patient safety recommendation is screening for colon cancer with a colonoscopy and biopsies every 1 to 2 years, typically starting after the disease has been present for about 7 to 8 years.
Now, let's shift our focus to a broader protective system within the body, inflammation. What exactly is inflammation in basic terms?
Right. Inflammation is essentially your body's adaptive and non-specific response mechanism. It's a fundamental way the body protects itself when faced with injury or infection. The process involves removing damaged cells, bacteria, and exudate. That's the fluid that leaks from blood vessels during inflammation, primarily through a process called phagocytosis, which is like a cellular cleanup crew performing debridement.
And what are those classic 5 cardinal signs that often tell us inflammation is happening?
Yes, the classic 5 signs. They are redness or rubor, warmth calor, swelling tumor, pain bullard, and impaired function, functionalisa, of the affected area. You'll also notice many medical terms for inflammatory conditions end with the suffix KLAs, like appendicitis, conjunctivitis, hepatitis, indicating an inflammatory process is involved.
Is inflammation always the same?
No, it's a complex response of vascular tissues triggered by various harmful stimuli. We generally differentiate between acute inflammation, which is an immediate, usually short-term response to injury or infection, and chronic inflammation, which is a more persistent response, often because the triggering agent or irritation continues over a longer period.
What are the typical stages inflammation goes through?
It usually progresses through several stages. First, the vascular and cellular responses, where blood vessels dilate, blood flow increases, causing redness and warmth, and immune cells rush to the site. Second, exudate production, where fluid and cells accumulate at the site, causing swelling. Third, the reparative phase, where the body starts the process of cleaning up debris and beginning tissue repair. And finally, regeneration or replacement, where new tissue forms. Ideally, this is perfect regeneration, but often it involves replacement with scar tissue through processes known as primary or secondary intention healing.
Are there genetic or non-modifiable risk factors associated with certain inflammatory conditions?
Yes. Certain demographics seem to have increased risks for specific inflammatory conditions. For example, Native Americans and Mexican Americans have an increased risk for developing gallstones, which involves inflammation of the gallbladder. Female gender is a non-modifiable risk factor for certain autoimmune inflammatory conditions. African Americans are more likely to develop nephritis, kidney inflammation, as a complication of lupus. and a family history is often associated with conditions like peptic ulcer disease.
What diagnostic tests are commonly used to detect or monitor inflammation in the body?
Common blood tests used to detect and monitor inflammation include the erythrocyte sedimentation rate, ESR, which measures how quickly red blood cells settle in a test tube. Normal ranges are typically 0.15 mm for males and 0.20 mm for females, with higher rates indicating inflammation. Another key marker is C-reactive protein, CRP, which also rises significantly with inflammation. A WBC, white blood cell count with differential looks at the number and types of white blood cells, indicating an immune response. Other tests might include serum protein electrophoresis, SPL, routine chemistry panels, and sometimes skin testing if allergies are suspected as a trigger for inflammation.
How does general nursing care approach a patient experiencing inflammation? It seems like it would follow the nursing process.
Exactly, it follows the nursing process systematically. First is recognizing cues. This involves careful physical assessment, looking for those cardinal signs and other symptoms, which can vary greatly depending on whether the inflammation is localized or widespread. Second is analyzing cues, identifying potential problems or nursing diagnoses based on the collected information. Third is prioritize and generate solutions. This involves setting goals aimed at reducing inflammation, determining the most likely underlying condition, identifying the best possible outcome for the patient, and developing a comprehensive plan of care.
And then taking action.
Right. Fourth is take action. This means implementing the plan, administering medications like anti-inflammatories or pain relievers, and performing procedures as prescribed. Crucially, it also involves teaching the patient about their condition, the treatment plan, and self-care measures. This patient education is a vital HCP communication and patient safety role. Finally, evaluate. We assess if the treatment and care were effective in reducing inflammation and symptoms, and also assess if the patient is able to demonstrate understanding of the teaching provided, ensuring patient education and safety goals are met.
Okay, let's apply that to a specific and often emergent inflammatory condition, appendicitis. What's happening in the body when the appendix gets inflamed?
Right, appendicitis. The appendix is that small finger-like, tube-like pouch attached to the cecum, which is the beginning of the large intestine. It's typically located in the right lower abdomen, just below where the small intestine joins the large intestine, a spot often referred to anatomically as McBurney's point. Appendicitis occurs when the opening or proximal lumen of this pouch becomes obstructed. This obstruction traps mucus and bacteria inside, leading to inflammation, swelling, and infection.
And why is this considered an emergency? What's the major risk?
This is a critical patient safety point. If appendicitis is not treated promptly, the inflamed appendix can perforate or rupture. This spills infectious contents into the abdominal cavity, leading to peritonitis, a widespread and very serious inflammation of the abdominal lining. Peritonitis is a life-threatening emergency requiring immediate intervention. Other potential major complications include gangrene, tissue death of the appendix, abscess formation, a walled-off collection of pus, and septic thrombosis, infected blood clots.
What typically causes that initial obstruction?
The obstruction can be caused by various things. Most commonly, it's a fecalith, basically, a small, hardened piece of stool that gets lodged in the opening. It can also be caused by a calculous stone, parasites, swelling edema of the lymphoid tissue within the appendix wall, often after a viral infection, occasionally a tumor, or even a foreign body that's been swallowed. Once obstructed, mucus secretion continues inside the appendix, pressure builds up, blood flow gets cut off, ischemia, leading to inflammation, cellular death, and ulceration of the lining.
What are the classic clinical manifestations of appendicitis, especially that characteristic pain pattern?
The pain presentation is quite typical, though not always textbook. It usually begins as a dull, persistent pain felt around the umbilicus, the belly button. But here's the hallmark and unique symptom that often develops. This pain then classically moves or shifts downwards and to the right, localizing in the RLQ, right lower quadrant, of the abdomen, often over McBurney's point.
So pain migration is key.
Yes, that migration is a very common feature. The pain is typically aggravated by moving, walking, or coughing. On physical examination, there's often tenderness, guarding, tensing abdominal muscles, and rebound tenderness, meaning pain is worse when the examiner quickly releases pressure after palpating the RLQ. It's important to note, though, that symptoms, especially pain localization, may be less acute or present atypically in older adults or very young children, sometimes making the diagnosis more challenging in those groups.
What are the primary complications again, just to reiterate the risks?
The primary most feared complications are perforation, rupture, leading to peritonitis, infection of the abdominal cavity, abscess formation, and potentially chronic appendicitis, though this is less common. All of these represent severe patient safety risks.
How is appendicitis typically diagnosed and treated?
Diagnosis often involves a combination of clinical assessment and diagnostic tests. An abdominal ultrasound or CT scan is frequently used to visualize the appendix and confirm inflammation or rule out other causes of abdominal pain. An X-ray might be done, but is less specific. A urinalysis is usually performed to rule out urinary tract issues like a kidney stone or UTI. A WBC, white blood cell count with differential, is typically checked, and it usually shows an elevated white blood cell count, indicating infection and inflammation.
And the treatment?
The definitive treatment of choice for acute appendicitis is an appendectomy, the surgical removal of the appendix. This can usually be done via a minimally invasive laparoscopic approach, using small incisions in a camera, or sometimes requires a traditional laparotomy, open surgery. And here's a crucial patient safety instruction before surgery. Patients should be kept strictly NPO, nothing by mouth, to prevent the risk of aspiration during anesthesia.
What about medications?
Pharmacologic therapy is supportive. Analgesics are given for pain management. Antiemetics might be needed for nausea and vomiting. And antibiotics are usually started preoperatively and may continue postoperatively to treat the infection and prevent complications like wound infection or abscess.
What are the priority nursing interventions for a patient with suspected or confirmed appendicitis, both before and after surgery? And any critical safety warnings we need to remember?
Nursing care involves rapid assessment, analysis of the situation, prioritizing interventions based on risk, generating solutions within the plan of care, taking action, and continuously evaluating the patient's response. Priority nursing interventions start immediately, maintain strict NPO status, and initiate IV access right away for fluids and antibiotics. These are critical patient safety measures.
Okay, NPO and IV access immediately.
Yes. Pain management is also a high priority for patient comfort. Post-surgery, we typically position the patient in a Fowler's position, semi-sitting, which can help promote comfort, drainage, and lung expansion. If surgical drains, like a GP drain, are placed, we monitor the drainage carefully. A specific point for HCP communication and patient safety is to report drainage greater than 500 milliliter total after the first 48 hours, as this could indicate potential hemorrhage or other issues.
What signs of complications should nurses watch for closely?
We need to observe very carefully for any signs of postoperative complications, particularly peritonitis or abscess formation. These signs would necessitate immediate HCP communication and include things like returning or worsening anorexia, nausea, vomiting, abnormal or increasing abdominal pain, or the patient starting to develop a fever and chills.
And that critical safety warning.
Yes, the critical patient safety warning. Do not apply heat, like a heating pad, to the painful abdominal area, either preoperatively or immediately postoperatively for appendicitis. While heat might feel soothing for some types of pain, in appendicitis, it can increase blood flow to the inflamed appendix and potentially increase the risk of or hasten rupture. So, no heat.
Good to remember, no heat for appendicitis pain. Okay, let's move to another significant inflammatory condition, hepatitis, which specifically affects the liver. What causes it, and what are the main types we should know about?
Right. Hepatitis simply means inflammation of the liver. This inflammation can be caused by various things, most commonly viruses, hepatitis A, B, C, D, E viruses, but also by other toxic substances such as excessive alcohol consumption or certain medications that can be harmful to the liver. When hepatitis occurs, the causative agent, whether it's a virus or a toxin, damages or kills liver cells, hepatocytes. This triggers an inflammatory response and impairs the liver's many crucial functions, including those vital for digestion, like bile production, detoxification of substances from the blood, and production of blood clotting factors.
Can you remind us of those memory tricks for remembering the transmission routes of the different viral types? That was helpful.
Sure. For hepatitis A, transmission is primarily via the fecal-oral route, often through contaminated food or water. Think A for anus to mouth. For hepatitis B and hepatitis C, transmission is mainly through exposure to infected blood and body fluids. This includes things like sharing needles during IV drug use, getting tattoos or body piercings with unsterilized equipment, sharing personal items like razors, or having unprotected sex. Think B and C for blood cultures and sex. Specifically, Hep B is transmitted parenterally via blood and sexually through contact with contaminated blood or secretions like saliva and semen. Hep C is most commonly associated with percutaneous exposure through the skin to infected blood, especially among IV drug users.
Okay, A is fecal oral, B and C are blood body fluids. What about D and E?
Hepatitis D is a bit unique. It's considered a satellite virus. because it can only infect individuals who are already infected with hepatitis B. So its mode of transmission is the same as hepatitis B, blood and body fluids. And hepatitis E is similar to Hep A. It's transmitted via the fecal-oral route, typically through contaminated drinking water, particularly in areas with poor sanitation. Think E for E. coli is in the water.
Got it. What are the general risk factors for contracting hepatitis?
General risk factors really revolve around potential exposure. This includes direct exposure to infected blood and body fluids, close personal contact with infected persons, especially for Hep A and E household contacts, poor personal hygiene habits, inadequate sanitation infrastructure, and having underlying liver disease, which might make the liver more vulnerable. Specific risk factors apply more strongly to certain types, as we discussed, like living in or traveling to areas with poor sanitation for Hep AE, being a healthcare worker, IV drug user, or dialysis patient for Hep B, or engaging in high-risk sexual practices or having received blood transfusions before widespread screening began around 1992 for Hep C.
What are the typical clinical manifestations? What unique signs should make someone suspect liver involvement?
Initially, the symptoms can be quite vague and flu-like. Things like headache, fever, fatigue, or malaise, nausea, and vomiting are common in the early phase. But as the liver becomes more inflamed, crucial and more unique signs pointing towards liver involvement start to appear. These include elevated liver enzymes, like ALT and AST, and elevated bilirubin levels found in blood tests. Patients often experience generalized itching, pruritus, which is thought to be due to bile salts depositing under the skin.
And the classic sign.
The classic sign is jaundice, which is a yellowing of the skin and the whites of the eyes, sclera, caused by a buildup of bilirubin. You might also see clay-colored stools because bile pigment isn't reaching the intestines properly, and dark tea-colored urine because the kidneys are trying to excrete the excess bilirubin. Other potential signs include easy bruising due to elevated PT-PTT, problems with blood clotting factors produced by the liver. This is a patient safety concern for bleeding. Low albumin levels, another protein made by the liver, can lead to edema, swelling.
What about chronic hepatitis?
If hepatitis becomes chronic, particularly with Hep B or C, more severe signs related to long-term liver damage can develop. These might include palmar erythema, redness of the palms, spider angiomas, small spider-like blood vessels on the skin, worsening bleeding disorders, a significant patient safety issue, lower extremity edema, ascites, fluid accumulation in the abdomen, swollen lymph nodes, and signs of impaired brain function called hepatic encephalopathy. Confusion, personality changes, disorientation, which is a neurological patient safety emergency. You might also see ascarixis, often called liver flap, which is a flapping tremor of the hands when they're held outstretched.
How is hepatitis definitively diagnosed?
Specific blood tests for viral antigens or antibodies confirm the type of viral hepatitis. While clinical signs and lab tests are key, the definitive diagnostic test to assess the extent of liver damage and inflammation is often a liver biopsy, and this is an important patient safety instruction. After the biopsy procedure, the patient should be positioned lying on the right side for a period of time. This applies pressure to the biopsy site on the liver, helping to prevent bleeding, which is a potential complication. Other lab tests routinely monitored include those liver enzymes, ALT, ALP, AST, serum bilirubin, prothrombin time, PT, and a complete blood count, CBC.
How is hepatitis typically treated with medications?
Treatment really depends on the type and severity. Those cases of acute viral hepatitis, particularly hepatitis A, are self-limiting and recover without specific pharmacologic treatment, often just requiring supportive care, like bed rest. For prevention or post-exposure prophylaxis, vaccines, available for Hep A and Hep B, or immune globulin might be given. For chronic hepatitis B and C, antiviral medications are the mainstay of treatment. Interferon alpha was used more in the past. Now, particularly for hepatitis C, highly effective direct-acting antiviral DAA agents are available. These specifically target different steps in the Hep C virus replication cycle, leading to very high cure rates by lowering the viral load significantly. Hep B treatment often involves long-term antiviral therapy to suppress the virus.
What's the nursing care focus for patients with hepatitis? What are the critical safety points and supportive measures?
Nursing care is primarily supportive, focusing on promoting recovery and preventing complications and transmission. We encourage rest and proper nutrition, often suggesting small, frequent meals that are low in protein and fat initially, especially if nausea is present, gradually advancing the diet as tolerated. For patient safety, it's absolutely crucial to advise patients to completely avoid alcohol, as alcohol puts significant additional strain on an already inflamed liver and can worsen damage.
What about preventing spread?
For prevention of transmission, especially in a healthcare setting or at home, we diligently observe standard precautions and contact precautions if the patient is incontinent for Hep AE. This is a core patient safety intervention. Priority nursing interventions include providing frequent rest periods and clustering activities to conserve the patient's energy. If the patient is hospitalized and immobile, applying anti-embolism stockings helps prevent blood clots, DVTs.
What else do nurses monitor?
We administer prescribed drugs and meticulously monitor the patient's response and watch for any potential side effects. We encourage adequate oral fluid intake and may administer POR-V fluids if necessary to maintain hydration. Key assessments include regularly measuring abdominal girth to check for worsening ascites, inspecting stool characteristics, and gently palpating the spleen and liver, checking for enlargement or tenderness. Given the potential for complications like bleeding or confusion encephalopathy, we institute safety precautions as needed, such as fall precautions or measures to prevent injury from bleeding.
Are there common complications to watch for?
Yes, dehydration and electrolyte imbalances, like hyperkalemia, can be common, especially with significant nausea or vomiting. Nurses need to monitor closely for signs of serious complications like portal hypertension, increased pressure in the portal vein system, and hepatic encephalopathy. Both are severe patient safety concerns requiring prompt recognition and management.
What are the key prevention messages for personal and public health regarding hepatitis?
Prevention is multifaceted. Good hand washing is paramount, especially for preventing fecal-oral transmission of Hep A and E. Vaccines are available and highly effective for preventing hepatitis A and B. The Hep A vaccine typically requires 2 doses given about 6 months apart. Implementing needle precautions, safe injection practices, avoiding sharing needles, avoiding unprotected contact with potentially infected body fluids, rigorous blood donor screening, and routine testing of pregnant women for Hep B are all essential public health measures. And a crucial patient safety rule for personal care. Do not share personal care products like razors or toothbrushes, as these items can easily transmit bloodborne viruses like Hep B and C if contaminated.
What about managing that itching symptom?
For managing the often distressing itching, pruritus, associated with hepatitis, recommend keeping the skin cool with cold compresses, using moisturizers liberally, and avoiding things that can worsen itching, like excessive heat or harsh soaps.
Let's turn our attention now to pancreatitis, inflammation of the pancreas. What exactly is this and how serious can it be?
Pancreatitis is, as the name suggests, an inflammation of the pancreas, which is that vital organ tucked behind the stomach, responsible for producing important digestive enzymes and hormones like insulin. This inflammation can range quite dramatically in severity, from a mild, self-limiting episode causing discomfort to a severe, life-threatening condition. Acute forms of pancreatitis can have a significant mortality rate, estimated between 10–30% in severe cases. Chronic pancreatitis, on the other hand, causes irreversible tissue damage over time and progresses to a significant permanent loss of pancreatic function.
What's happening physiologically in pancreatitis? You mentioned this concept of autodigestion earlier. Can you explain that?
Yes, autodigestion is the core pathological process in acute pancreatitis. It involves the premature activation of the pancreas's own powerful digestive enzymes inside the pancreas itself, rather than being released into the small intestine where they're supposed to work. Normally, these enzymes are secreted in an inactive form and only become active once they reach the duodenum. But if the pancreatic duct gets blocked, often by a gallstone or inflammation, or if there's direct injury to the pancreatic cells, these enzymes can become activated prematurely within the pancreas.
And what happens then?
Once activated, these enzymes literally start to digest the pancreatic tissue itself, hence autodigestion. Key enzymes involved include protease, which breaks down protein, lipase, which breaks down fats, and its levels are often the most significantly affected and specific indicator in blood tests for pancreatitis, and amylase, which breaks down carbohydrates. This autodigestion leads to inflammation, swelling, bleeding, and potentially necrosis, tissue death, within the pancreas.
And how does chronic pancreatitis differ from this acute process?
Chronic pancreatitis is characterized by ongoing, persistent inflammation, leading to progressive fibrosis, scarring, and gradual destruction of the functional pancreatic tissue, both the exocrine tissue producing enzymes and the endocrine tissue producing hormones like insulin. This ultimately results in irreversible pancreatic insufficiency, meaning the pancreas can no longer adequately perform its digestive or hormonal functions. It often involves chronic changes in enzyme and hormone production.
What are the main risk factors for developing acute versus chronic pancreatitis?
For acute pancreatitis, the two most common causes by far are alcoholism and gallstones, specifically gallstones that block the common bile duct near where the pancreatic duct enters. Other contributing factors include smoking, obesity, underlying biliary tract disease, physical trauma to the abdomen, and the use of certain drugs. This is a specific medication consideration, as some drugs are known to potentially trigger pancreatitis.
And for chronic pancreatitis?
For chronic pancreatitis, the primary association is with long-term alcohol abuse. Smoking is also a major risk factor for developing and worsening chronic pancreatitis. Other causes include recurrent episodes of acute pancreatitis, hereditary factors, autoimmune conditions, and sometimes conditions like hypertriglyceridemia, very high levels of fats in the blood.
Are there distinct pain patterns that help differentiate acute from chronic pancreatitis? What are the unique signs and symptoms to listen for?
Yes, understanding the pain differences is quite helpful clinically. For acute pancreatitis, the onset is typically abrupt, with continuous, severe epigastric upper abdominal pain that uniquely radiates straight through to the back. Patients often describe it as a deep, boring pain. The pain might be somewhat relieved by sitting up or leaning forward, but it's characteristically aggravated by eating, especially fatty foods, drinking alcohol, walking, or lying down flat.
What other symptoms accompany the acute pain?
Besides the severe pain, other common symptoms of acute pancreatitis include bloating, sometimes diarrhea, tachycardia, fast heart rate, and potentially hypotension, low blood pressure if it's severe, and elevated temperature, fever, significant nausea and vomiting, and sometimes cold, clammy skin indicating shock.
How does the pain typically present in chronic pancreatitis?
In chronic pancreatitis, the pain can be more variable. It might be intermittent episodes of severe pain similar to acute attacks, or it can be a more constant, dull, aching pain, typically felt in the left upper abdominal quadrant, which also often radiates to the back. Like acute pain, it's often aggravated by consuming fatty foods or alcohol. Other characteristic symptoms of chronic pancreatitis reflect the progressive loss of function, chronic weight loss due to malabsorption and pain with eating, constipation, and steatorrhea, which are fatty, bulky, foul-smelling stools that occur because the pancreas isn't producing enough lipase to digest fats properly.
What are the potential long-term complications of pancreatitis?
Complications can arise from both acute and chronic forms. These include the formation of a pancreatic pseudocyst, a collection of fluid around the pancreas, or an abscess, an infected collection. Damage to the insulin-producing cells can lead to diabetes mellitus, and unfortunately, chronic pancreatitis significantly increases the long-term risk of developing pancreatic cancer.
How is pancreatitis typically diagnosed?
Diagnosis relies on a combination of clinical presentation, laboratory tests, and imaging. Key imaging studies include ultrasonography, especially useful for detecting gallstones, endoscopic ultrasonography, EUS, provides detailed images, contrast-enhanced CT scan, often the preferred imaging for assessing severity and complications like necrosis, and sometimes a percutaneous fine needle aspiration biopsy if infection of necrotic tissue is suspected.
And the key lab tests.
Key labs are crucial for diagnosis and monitoring. Elevated levels of serum amylase and lipase, pancreatic enzymes, are characteristic of acute pancreatitis, with lipase generally being more specific and staying elevated longer. Blood glucose levels may be high, triglyceride levels should be checked, serum calcium levels might be low in severe cases, and examining the stool for excess fat content confirms steatorrhea in chronic pancreatitis.
What's the pharmacologic therapy approach for pancreatitis?
And pharmacologic therapy focuses on managing symptoms and complications. Opioid analgesics are typically required for the severe pain control, making pain management a critical priority nursing intervention. For chronic pancreatitis with exocrine insufficiency, pancreatic enzyme supplements containing lipase, protease, and amylase are prescribed to be taken with meals to aid digestion. Proton pump inhibitors, PPIs, might be used to reduce stomach acid, which can help the enzyme supplements work better. Antispasmodics are sometimes used, though their effectiveness is debatable.
Nutrition seems like it would be extremely important, especially that NPO status you mentioned for acute episodes. Can you elaborate on the critical dietary considerations?
Nutrition management is absolutely critical, particularly in acute pancreatitis, for patient safety and recovery. During acute episodes, patients are typically kept strictly NPO, nothing by mouth. This is done to rest the pancreas, reducing its stimulation to secrete enzymes, which helps decrease inflammation. This is a critical patient safety measure.
So NPO initially, how do they get nutrition then?
5 fluids are administered aggressively to maintain vascular volume, prevent dehydration, which can worsen pancreatic damage, and support organ perfusion. If the patient needs to be NPO for an extended period, total parenteral nutrition, TPN, providing complete nutritional support intravenously may be necessary.
And when they can start eating again.
When oral food intake is gradually resumed after an acute episode, it typically starts with clear liquids and slowly advances to a strict low-fat diet. Fat intake needs to be limited because fat is the primary stimulant for pancreatic enzyme secretion. And crucially, for both acute recovery and long-term management of chronic pancreatitis, patients must completely avoid alcohol. Alcohol is a major trigger for pancreatitis flare-ups and is directly toxic to the pancreas, worsening damage. This avoidance is a critical patient safety and lifestyle change.
What are the surgical options that might be considered for pancreatitis?
Surgery isn't typically the primary treatment for the inflammation itself, but it plays a role in managing complications or underlying causes. For pancreatitis caused by gallstones, an endoscopic procedure called ERCP with sphincterotomy might be done to remove stones blocking the bile or pancreatic duct. A cholecystectomy, gallbladder removal, is usually recommended after recovery from gallstone pancreatitis to prevent recurrence. For chronic pancreatitis, surgery might be considered for pain relief, potentially involving procedures to drain blocked pancreatic ducts, remove part of the pancreas, or even block nerve pathways. Large or symptomatic pancreatic pseudocysts may require endoscopic or surgical drainage.
Finally, what's the nursing care focus for pancreatitis? What are the absolute priority interventions and key patient education points?
Nursing care involves the full nursing process, continuously assessing for and analyzing cues like pain levels, vital signs, fluid balance, nutritional status, prioritizing interventions based on the highest risk, for example, pain, fluid deficit, impaired nutrition, generating solutions within the plan of care, taking action and evaluating the effectiveness of those actions.
What's the top priority?
Pain management is absolutely a critical priority nursing intervention for these patients due to the often severe nature of pancreatic pain. We work closely with the healthcare team to ensure adequate analgesia. As discussed, maintaining NPO status strictly as ordered during acute phases is vital for patient safety. We meticulously monitor laboratory values, particularly pancreatic enzymes, amylase, lipase, glucose levels, watching for hyperglycemia, calcium levels, and indicators of hydration and nutrition.
And patient education.
Extensive patient education is crucial, focusing on the necessary dietary restrictions, low fat, and the absolute importance of lifelong abstinence from alcohol. This is vital for preventing flare-ups, slowing disease progression in chronic cases, and overall patient safety. We also provide comprehensive pre- and post-operative care as needed if the patient undergoes any surgical procedures related to their pancreatitis.